Thank you very much, Senator Ralph Recto. Please remain on stage as we call up our speaker, Secretary Jokno, and our panelists for the session, Optimizing Resource Allocation for Health. Our panelists are, she is the Chief of the Health Research Division of the Department of Health's Health Policy Development and Planning Bureau. Prior to this, she worked on health financing reforms as a consultant on the Asian Development Bank's health sector group and as executive assistant at the Philippine Health Insurance Corporation. She teaches health policy to pre-med students at the Ateneo de Manila University. Let us welcome Dr. Beverly Lorraine Ho. Our next panelist is the OIC Senior Vice President of PhilHealth's Health Finance Policy Sector. He has more than a decade of experience in public service that spans frontline LGU health operations to central policy and program development in public health and social health insurance at the DOH and PhilHealth. We now welcome Dr. Francisco Soria. Also joining the panel is the current Assistant General Manager for Charity Sector of the Philippine Charity Sweepstakes Office, where he held various positions since 1992. Please welcome Dr. Larry Cedro. We are also pleased to have with us the former president of Insular Life Healthcare Incorporated, a premier HMO in the country today, and the former president and currently the executive director of the Association of Health Maintenance Organizations of the Philippines. Please welcome Mr. Carlos Da Silva. We also welcome back Janet Loreto Garin, former Secretary of Health, and Dr. Eduardo Banzon of the Principal Health Specialists of ADB to moderate this session.
Thank you very much. Sa mga hindi nakakaalam, for those who do not know, when I was Secretary of Health and I will be called to the office of Senator Recto, I would always bring two calculators. Why? Because at the back of his hand, he knows health insurance and health financing in and out. And that's why with the presence of Secretary Jokno, who hit the problem right in the aorta of healthcare, as he mentioned that devolution did more harm than good. Sir, we strongly agree, because that's a very big problem that has now been infecting the healthcare. And with this, as Secretary Jokno is here and Senator Recto is here, with all our stakeholders, it may be a platform to again push forward a proposal that we had, that PhilHealth membership, in order to achieve and to make and to optimize resources and to make primary care system work on a family basis, but on an individual basis. Because if you talk about universal coverage, when you reach 19 and you become excited and you have a baby, your baby is not covered, that 18 or 19-year-old mother is not covered, and when that minor again gets pregnant, that minor plus the grandchild is not covered. And with that, Your Honor, we have now Dr. Dodo Banzon.
Thank you, Janet. So we have heard Secretary Jokno talk about nearly 120, quite a huge budget that we have. I remember first time I was working with DOH, we're talking about 8 to 9 billion, and we're talking triple figures. And it presented very, very huge sums about of money of what they're doing. Senator Recto has proposed some quite innovative approaches on how to move forward with our universal healthcare reform. So maybe I'll start with Dr. Ho to give her comments from the perspective of the Department of Health.
Oh, thank Good afternoon. Basically, what I will be sharing with you are the main strategies of the updated healthcare financing strategy that the Department of Health has developed. So we heard about the many increasing funds that the department has received throughout the years. But I guess what's not clear to an outsider or looking at it from the outside perspective is where do these funds go and how do they translate to outcomes in the future. So where we're seeing the financing of the Department of Health headed to is, first of all, we'd want to, in a way, pool all these fragmented financing. So Senator Recto has said we want to pool the funds of PCSO, all these other agencies, towards a single fund that shall become sort of like the national purchaser that we'll have. It will enable, first of all, better use of resources. So you'll only have one priority setting mechanism, not several agencies doing separate priority setting mechanisms. And number two, with a good priority setting mechanism, this agency will also be able to purchase, negotiate properly, which currently we don't have. This priority setting mechanism is what more technical people would call health technology assessment. And it's not that we're not doing it now. We're doing it on a certain level for the Philippine National Formulary, but we haven't really linked it up to any price negotiation scheme. So in many other countries, the national government does a framework contract for which all other national government bodies can access the price of that good or commodity at a certain price. So probably that's one of the things we want to do for the pooling and purchasing part. In terms of what should be the division, who pays for what? Basically, in the health financing strategy, we divide the services not as promotive, preventive, and curative, which is how we did it a long time or for a long time, but to divide it as population-based or individual-based. Why? Because a lot of preventive and promotive health services can actually be traced to an individual and hence can be paid for by your purchaser. So currently, the only constraint for that, which some people might disagree, PhilHealth paying for outpatient services, would be that it should be a non-reimbursable service. But then we're seeing that health systems all over the world, we're moving towards a non-traditional insurance type of system where your national purchaser can actually really pay for these preventive and promotive services. So where we're looking at is that eventually the DOH and the LGUs, so the national government and the LGUs, will pay for the population-based services, information education campaigns, fumigation, water and sanitation, and then your national purchaser, which would be PhilHealth de facto, would pay for all the individual level services. So all the commodities, actually it should shift towards the national purchaser, which should actually do all your negotiations.
So, sorry, Dr. Arjo talk about pooling, to talk about purchasing, to talk about PhilHealth, hard to say. So let, Arya, would you like to give your views about this?
Good afternoon, everyone. It was encouraging to listen to Secretary Jokno mentioning all those figures. But I think what stuck to my mind, my take-home message from his speech was his sentence at the last part of his speech that, wherein he said that let us use these funds efficiently and effectively. I think in health, as in life, we often get what we pay for. And if we pay for garbage, we get garbage. So in health, we have to prioritize things. We have to think of allocative efficiency. And I think there's a lot of effort towards achieving allocative efficiency in the health system now, with the Philippine Health Agenda providing the framework for such. In fact, in the DOH, and part of that is PhilHealth, there's a discussion on the guaranteed health benefits, which are both population-based and individual-based, as mentioned by Dr. Bev. I used to work with her, but I'm having senior moments right now. In fact, I prepared a spiel, but I think I have to do away with that, considering that in the point of view of PhilHealth, we usually get to meet all these concerns in the primary care level, in the tertiary care level, in the curative level, the issues on supply side issues. I think the problem with the supply side is present at all levels of care. It's not only at the primary care level. And it's encouraging that a lot of resources are now being provided for this at all levels. And for example, in our Z benefits package, we're having problem taking it off because of the limited service capability in even in tertiary hospitals to provide highly specialized care. Even in the primary care benefit, we're having problems. In fact, the baseline survey conducted by a technical group noted that only roughly 50% have laboratory services among the rural health units. And roughly 5% only have X-ray facilities. So if we're going to design our benefit package from PhilHealth, incorporating these diagnostic tests to be provided by rural health units, who will be the providers among the LGUs? How many LGUs would be capable to deliver the diagnostic packages, given this picture of service capability, dearth in service capability? So that's one issue from the supply side, that even with the demand side, getting more resources for health, as mentioned by Senate Secretary Jokno, for the National Health Insurance Program enrollment of the PAMANA, the indigent, and the senior citizens, there are still issues as far as supply side is concerned. It happens at all levels.
Yeah, thanks, Watch. Sorry. Watch, you should not say senior moments magkaklase at sa med school. So that makes me old as well. So let's now have Larry from PCSO.
Good afternoon, ladies and gentlemen. As I was listening to Senator Recto, I'm happy to hear that everyone here looks at PCSO as an institution, as well-managed institution with the revenues that we've raised. And just briefly, we started at 2 million allocation for medical assistance program. But right now, we're spending 18 million a day. So if you will look at the markup in terms of fund distribution, fund utilization, clearly, you can attribute that to good governance. But then again, we are reminded of the role of the PCSO in healthcare financing. We're here to augment. We cannot cover for all. There are several measures being instituted by the agency to maximize its resources. This year, we're excited with the expansion of our games, but at the same time, we're quite reserved in terms of dealing with other situations such as legal issues affecting our games, affecting our services. So those are the things that we have to look at. No? To address this issue, we are preparing, again, as I've mentioned, innovations. There will be changes in the manner we provide assistance. There will be changes in the manner the amount is being given, the delivery system is being given. You must have heard of ASAP. That's one step. We are trying to enter into several agreements with various hospitals. Instead of people going to PCSO, it's now PCSO working inside that institution. And more than that, no, my colleagues here, no, we're trying to come up with the realization, hopefully, of the term universal health care. And we're confident that, meaning, hopefully this year we can attain that. So that's the plan right now as far as PCSO is concerned, sir.
Thanks. And finally, we'll have Carlos to briefly talk about the role of it.
earlier, Dr. Banson here mentioned that throughout the presentation this morning, he was hoping to hear something about the private sector, and rightfully so. And for Dr. Garin, earlier, Dr. Garin mentioned that she mentioned a lot of government agencies that contributed to the reduction by 50% of the out-of-pocket expenditures. I was hoping that the private sector, the HMOs, because that's where I'm coming from, would be mentioned. Another one that I'd like to mention would be, throughout the day, we've been mentioning Juan and Juana. I am a Juan, you are one, you are all Juanas. We are not poor. I mean, the focus, as I hear it the whole day, is focusing on the poor, the poorest of the poor, and the marginalized. I mean, a Juan and Juana may be not poor. That's me. I may not be poor. But the initiative of health for a Juan and Juana should be for all Filipinos, not only for the marginalized sector of our society. That's where I'm coming from. Magandang araw. Okay, allow me to cut to the chase and highlight some of the important aspects of our topic, and later on tie it up with HMO financing and resource allocation from an individual plan holder's and a corporate client's perspective. The increasing cost of health services in developed and developing countries has stimulated greater interest in the utilization and financing of prepaid managed health care. HMOs operate on that principle, prepaid managed care, health care. In the May 1987 World Health Assembly in Geneva, going back in history, the central issue was how more resources can be generated, used more efficiently and effectively, and distributed more equitably to ensure health for all by the year 2000. And that's a good 30 years ago, and a good 17 years from 2000. Yet, worldwide, the thrusts are pretty much still the same. And especially in the Philippines, which is to establish the foundation of, as well as trigger, a sustained and systematic search for alternatives to current modes of planning, generating, distributing, and utilizing scarce resources for healthcare. Fast forward to 2015, it appears that the global movement to expand universal health coverage is well underway. Can I just stop there? Earlier, I've been hearing universal health coverage. I've been hearing universal health care. Ano ba talaga, kuya? Kuya? Coverage, the DOH uses care, the same. I think there's a hairline of a difference. You tell me which to use. Is it coverage or care? What? Coverage? The same. Okay, then. The professor has spoken. Okay, in September 2015, world leaders adopted the 2030 Agenda for Sustainable Development, which includes the goal of achieving universal health coverage for all by 2013. I used coverage. Health administrators in developing countries, in search of new and better ways to healthcare, realize that they have to start analyzing how healthcare is financed in both the private and the public sectors. To date, while progress has been made, little is known how public and private components of the existing health system affect each other. Thus, very little account is known how these sectors affect or influence each other. in the delivery of financing of health services. The Philippines is still in the process of evolving a rational and responsive national health financing policy which suits the country's health needs, given the existing patterns of producing, utilizing, and distributing health resources, something we are very glad is still very much present in the country's national health agenda. Last Thursday, I attended the second TWG meeting of 4 House bills, this was mentioned earlier, that aims to institutionalize a universal health care system in the country that would ensure that every Filipino, every Juan and Juana, including the poor and the marginalized, are able to attain the highest standards of health care. And quoting from the Department of Health's statements and Ted Padilla of the PHAP, who earlier said, healthcare that is accessible, efficient, equitably distributed, adequately funded, fairly financed, and appropriately used by an informed and empowered public. On HMOs and for individual accounts, health financing is often from one's personal resources and oftentimes from what's left from one's monthly budget. The priorities are different. Unfortunately, sadly, healthcare is hardly a priority for most Filipinos when they have to finance the same. However, for employers or corporate accounts, top priority under their employee benefits programs for HMO coverages funds for which are budgeted yearly and are part of the company's general administrative expenses. During our panel discussions later on, we shall hopefully be able to talk about how to optimize one's maximum benefit limit or aggregate benefit limit per illness or injury per year. Maraming salamat at magandang araw.
Thank you very much, Carlos. Allow us to wrap up some of the questions that came from the previous meetings that our panelists and speakers can address today. On the part of PhilHealth, as what earlier conveyed by Carlos Da Silva, there is this issue of when you want to reduce out-of-pocket expenditure. Is there an alignment between the private healthcare insurance providers and PhilHealth so that whatever they are providing will be symbiotically related? Ang ibig sabihin, yung ibang catastrophic diseases, pagka maliit ang coverage ng PhilHealth, it become a huge burden on the patient because the HMOs will only cover such an amount. And if we proceed to Senator Recto, you mentioned about the importance of water. Would you be agreeable, as Dr. Beverly Hall earlier said, that health and water comes together? Would you be agreeable in putting again water as a priority in health programs in the Department of Health? And for Secretary Jokno, who holds the key to making primary care systems work, because if you want primary care system and health to work, of course, you need government, and that is actually Secretary Jokno. Sir, there has been mentioned about human resource as a primary driver of universal health care and even universal health coverage. And true enough, you mentioned devolution. Doctors, nurses, and other healthcare personnel are being driven away, like mayors and governors and LGUs earlier mentioned, that they put up. But then the salaries that they pay is a very meager amount as compared to the items being created by the national government. So while we are creating items which are very good, it depletes towns, cities, and provinces of human resource. So would you allow in possibly crafting a way to lift the cap on salaries and allow on salaries in terms of LGUs?
I would go back to my proposal, re-centralize, okay, re-centralize. And then the government can hire doctors per municipality as proposed by, I don't have to wait, I don't have to educate them for 8 years before they go back. No? There are a lot of doctors, no? But they should be paid a premium. Those who will locate in the barrios should be paid a premium. Ganun naman talaga, di ba? With the hardship allowance. I think that's more manageable than spending 8 years, before they can become a doctor. But we can afford that, okay? But you have to, as I said, I'm now convinced more than ever that the devolution of health is a failed experiment, okay?
Sir, if you will allow me to pose a follow-up question, would you possibly convince the President to put renationalization of healthcare as a priority measure in Congress and Senate? You have Senator Recto anyway.
Now you need legislation to do that, so you have to convince Congress also, okay?
Senator Rec-
You know, when my wife was governor of the province of Batangas and me being her senior advisor, we would not agree to centralizing health in Batangas. Now, but having said that, I think the bigger problem is that the share of local government, and the reason why they're not able to deliver as promised under the local government code, is the share of local governments in the national budget is only 13 to 14%. Okay? Whereas the local government code talks about 40% of internal revenue allotment, 3 years preceding. That means what the national government collected 3 years ago, 40% of that, after 3 years, I will give back to you. The equivalent of that today is 13, 14%, maybe even lower, 12 to 14% of the national budget goes to local governments. While we have devolved health to the local governments, we did not devolve the resources. Okay? So that is also a half-truth of the matter. No? The other is that there are also local government officials who don't care about health. There are governors in certain provinces who don't really care about health. They would rather do dole-outs to get reelected instead of spending on their hospitals. There are many, we have many experiences. Like for example, COA. It is so difficult to bid out projects properly as well. And so many regulations of the central government with the local government units. And that is why it is no surprise that the President talks about federalism. I am against federalism. I think it is an extreme. I think what the President really wants is just more decentralization and devolution, including the resources. Maybe COA should understand better also the predicaments of local government units and other national government agencies, right? I'm sure. You know, I've seen all the COA reports in all the departments, including the health department, right? So, maraming problema talaga. So, why not Department of Health already have a list of suppliers, for example? Ito yung dumana sa amin, ito credible to mga to. O yun, pwedeng bilhin ng local government. Pag galing sa mga ganito. If that can be done. Na pwede na sa COA dapat yun. So there are many challenges that the local government faces too. And that's why they have all these problems. No? Now, Makati will not have a problem because in the first place, they don't need the IRA. Their local government revenues are sufficient. Quezon City, Manila. That's why we need to review the entire local government code as well. Thank you.
Our apologies, but there will be another session. I think it's always wonderful to leave a session at a high. We heard the budget secretary talk about recentralization of the health sector. I think the challenge now will be people in this room to make that proposal something that's written up and not just it's your job now to do the details on what you propose, how to bring back decentralization. And we heard a lot of insights on how local governments should. We apologize for the other panelists, but sure.
Just to follow up, the local governments, the absorptive capacity, their ability to spend is much higher than the national government. That is the problem with recentralizing. Today, I can tell you of the budget given to the Department of Health for 2017, I'll make a bet. A measly 10, 20% has only been spent.
And I think to respond to that, There will be another session, but we will be hopefully asking Secretary Jokno, Senator Recto, if they can come back on another forum where we will exclusively discuss recentralization, because I think it's high time, as said by Secretary Jokno, that this should be debated and discussed. So it's not because we're letting them go that you're not hearing from them, but we just need to have another final point that will become, and so let's give a big hand to our panelists.
Thank you very much, Senator Ralph Recto, Secretary Benjamin Jokno, Dr. Beverly Lorraine Ho, Dr. Francisco Soria, Dr. Larry Cedro, Mr. Carlos Da Silva, and Dr. Janet Garin for that fruitful exchange of ideas. We request you now to post your insights or reflections on our UHC wall. We also request former Secretary Dairit to post your comments. We are now down to the last and final panel session.
Service delivery points in terms of postpartum intrauterine device in the whole part of Zamboanga Peninsula, including Basilan, Sulu, and Tawi-Tawi. So the support of Zamboanga City Medical Center, a center of excellence, expanded, it goes beyond the region. And out of the 111, because of the training of trainers, building the capacity of our partners on the ground, we were able to reactivate 8 clinical practice sites to augment Zamboanga City Medical Center in terms of postpartum intrauterine device family planning services. And because of that, if you look into the data, from 2013 to 2016, you can see that there's already a reduction in the number of cases that is being supported or accessing services in Zamboanga City Medical Center, but there's all a spread of cases. While we are increasing the number of cases, it is now spreading along Zamboanga Peninsula for reasons that we have capacitated. So you are now increasing access of these services to our women for Juana and for Juan. See? So basically, that's for Zamboanga City, Zamboanga Peninsula. We're able to reach more than 6,000. But looking into the 19 provinces in 2 cities, we were able to reach 23,394 women who were provided with postpartum family planning services. And we were able to practically, I need to look into my, practically train 1,041 health service providers on postpartum family planning services. The challenge, though, as I was saying, using systems approach is that there's a lot of challenges along the way. While we were able to train 1,041, we were only able to do post-training evaluation to, these are, we were able to, for practically, we're able to do post-training evaluation to only 54% of what we train. And 34% were certified by the Department of Health. So basically, the challenge is in the post-training evaluation as well as in the certification for reasons that most of them lacked the confidence or they were not able to be followed up just after the training. Initially, it should be, the post-training evaluation should be done at least a month after the training, but the follow-up is being done later on the day. Also, in 2013, there were only 103 LGUs who has a capacity to provide postpartum family planning in Mindanao. But in 4 years, we were able to increase it to 731. And this is because there's a strong and good partnership between the project, the Regional Health Office, and the local government units, as well as the private sectors, because we are also we are also reaching out with our private sectors, which means that 75% of our 365 municipalities in our target areas have the capacity now to provide postpartum family planning. And how did we do this? Basically, we have key strategies, and we also focus on key areas in such a way that we can generate result. In everything we do it within the context of health system strengthening. In terms of increasing demand, we continue to optimize the capacity of the centers of excellence, that is including Southern Provincial Medical Center, Cotabato Regional Medical Center, Davao Regional Medical Center, and then Zamboanga City Medical Center. And we also expanded it to Northern Mindanao Medical Center. Also, we continuously work with the local government units in terms of training, supportive supervision, coordination with the DORO, so we're able to capacitate the capacity of our rural health units in other birthing facilities. In terms of generating demand, I think this is an area that has to be strengthened further, because while we have strengthened our profiling, identification of FP unmet need, the challenge is really addressing the fear of side effects and a lot of misconceptions on family planning methods. It's still a challenge. We went to one facility, we observed there's a very good master list, and if you try to look in one of the master lists as late in 2016, the desired family need of most of the women are limiting. But if you try to look into the services that was provided, it's pills, condoms, and the rest. So there is a mismatch because of those. It's because basically it's a behavioral thing, and we haven't been doing a lot of that. And I totally agree. We need to look into the primary healthcare component of a health system, or else we will never do that. In terms of sustainability and accountability, we work closely with PhilHealth for accreditation, as well as with the regional office for certification, as well as the implementation of existing facilities. Like the biggest challenge is establishment of FP programs in hospitals, because most of the time, while we are doing or supporting a lot of outreach services, it's not really cost effective. It's really building the capacity of our fixed facilities. We work closely with other development partners and the regional office to build the capacity of the facility. And I think the program of the Department of Health in terms of health facility enhancement program has contributed significantly in increasing the numbers of facilities that are practically now accredited on maternal care package as well as neonatal care package. It has increased to 97% are now accredited, and 88% of our LGUs, that is 300 out of 666, through a lot of series of advocacy, have now adopted the PhilHealth policy on reimbursement. And picking up from the data which coming from Health Policy Development Project of USAID, in Mindanao, there is an increase practically by 53% in terms of reimbursement, from 274 million in 2013 to practically 419 million in 2015. And that is the data from PhilHealth 2014-2015, care of our Health Policy Development Project. And while it's the importance because we are not starting from anything. We are picking up from the gains of previous initiatives of government as well as partners and bring them together to the front. It's consistently sustaining the gains as well as we were able to increase. And if you go to one of the facility that we have visited, the midwives are very happy in the sense that there are also additional incentives on every month because of these packages. And the quality of services are now improving. So it followed through. It followed through. So if you go down, it's really very important. Another major challenge is the use of data for actions. Most of the time, data are being collected to be submitted. During our field visits, they do data quality checks every 3 months because they need to submit it. So it's very important. So there are a lot of data quality checks that has been being done in the field, and we are happy that through series of advocacy, we already have 39 municipalities who are practically doing data quality checks. And the whole of ARM are basically doing also data quality checks for the whole of ARM LGUs. And also, we have 8 provinces who have released an executive order in order to do data quality checks in such a way that they will be used for their planning, for redirecting, as well as for advocacy to further leverage resources. One of the initiatives of Mindanao Health, closely working with the regional office, is the establishment of service delivery networks. We did not start from zero, but we did a lot of analysis, and we pick up from the interlocal health zones initiative of the Department of Health. And from when we started, there were actually still 6 service delivery networks that are practically doing co-sharing. And we pick it up from there while we are doing assessment of what is on the ground. We are also working with the regional office to develop the operational guide on how to establish service delivery network, anchored to the existing policy, the manual of operations on maternal neonatal care, as well as WHO guide on service delivery networks. The regions are now capacitated to establish service delivery networks. We also identify the uniqueness of these established delivery networks and identify what particular entry point that we can use to further tighten and strengthen the service delivery network. And so to date, we have 21 service delivery networks in Mindanao that we are working closely with the region, as well as the provincial health offices, covering 74 LGUs out of our 366 LGUs in our project sites. And today, the good thing that to date there are 2 that are practically operational. San Lakas, they were able now to agree a co-sharing of 50,000 per year. It's a small amount, but it's a starting point to collectively discuss among themselves, that is in Lanao del Sur. And then Iligan City, with a strong partnership with the private sectors, the mayor came up with an executive issuances, and with the concurrence of the private sectors, we already have 6 private sectors that are submitting their reports into the FHSIS of the city government. So it's now incorporated since last year. So those are the impact of, also through the service delivery network, we have worked closely with Davao Medical School Foundation, with the Southern Provincial Medical Center, and we were able to reactivate Marilog District Hospital, who has not been working, who has not been operational for more than a decade. And now, the AOH is now trying to enhance the building through the HPEF project, and hopefully it will be finished by June. And the focus, the good thing for Marilug District or District 3 of Davao City is that 70% also are indigenous peoples residing there. So the barangay councils are also providing some transport to ferry pregnant women and children to the district, as well as we have coordinated with the 111 of Davao City to transport, because the core referral of this service delivery network is Southern Provincial Medical Center. So what are the lessons learned that we have? There are many emerging practices worth replicating. Let's just go down. We need post-training evaluations are vital in capacity building. The capacity of the regional offices, the provincial government, the LGUs on data management, logistic management, and utilizations, systems building is one thing. Demand generation and its link to service provision, there's still a gap. People are doing FDS, but there's no link to the services. Or they're doing usapan, but with the support that we have been working closely, we are now trying to strengthen, but there's still a need to do more. And the changes in the political administrative environment has impacted the continuity of gains. There is a gap in terms of the implementations and localizations of policies at the LGU level. I was talking with one of the municipal health officers, and I said, do you know about all these policies from the DOH? I said, so how did you move? Oh, I just learned. I just know my data. I work with my mayor. We will just move. Policies there, but we don't, because we don't have even a copy. Health system strengthening requires multi-sectoral and multi-level collaboration. It's important to build on existing resources and opportunities, know the situation, strengthen what is available, innovate, but don't reinvent the wheel. Operationalizing the health system framework is tedious, process-oriented, and we need to balance the processes for significant results. As this morning, they were saying the fully immunized child is going downhill. Facility-based delivery is going up. For reasons that most of our midwives were now focused on the BMOC facility, disregarding some of the other public health programs, because there was no additional manpower. They use whatever is available. So our so some of the recommendations that we're trying to push forward is build the capacity of the regional medical centers, selected provincial hospitals on supportive supervision and post-training evaluation. Because most of the training that we have in these centers are also an added work to them. They are the providers in the hospitals. We just coordinate and ask for support for them to do the post-training evaluation. Strengthen the skills of the primary technical assistant providers, like the regional health offices, provincial health offices, in terms of health system strengthening. There should be a paradigm shift in terms of the capacity of our primary PA provider or the oversight body. Health system strengthening, public-private partnership, data management, equity-focused approaches. And I think it would be nice to do also a rapid assessment on the extent of the implementations of all these national laws. Are they reinforcing each other? How is it being localized on the ground, given the fact that it's a devolved setup? And also, there's a need to strengthen the functionality and coordination across and among existing structures, from the NIT to the RIT to the RDC, SDC to PDC. We have a very good example, which we try to support, working closely with the Davao region as well as Northern Mindanao. We access the Social Development Council and sell some health-related issuances or adaptations of policies at the level of the RDC. So it's easier because most of the participants in the RIT are provincial health officers. And you cannot easily guarantee whatever agreements there are being adapted on the ground. So you have to sell using the RDC approach. I think that's and then strengthen structures, mechanisms of being guarantee number 2 of the Philippine Health Agenda. We need to further really use service delivery network, but we do it slowly. Start with one thematic area, gradually embracing other thematic areas, rather than doing it in one go. It will be very, very difficult. Document and replicate good emerging practices, as well as improve our on-the-job mentoring. We need to be there. We are the oversight body, and yet we seldom go to the field. So, as I agree, health system strengthening is difficult, but there is hope. It has been shown. There's a lot of our problems, but it can be done. If we put a front, Juana in Juan, in our agenda, as the center of our agenda. Thank you po.
Thank you, Dr. Cayadan. Please remain on stage as we call on our panelists for the session, Imperatives for Sustainable Implementation. Our first panelist is the Regional Vice President of PhilHealth Regional Office 3. He is known for his many innovations and fruitful partnerships with stakeholders towards improving PhilHealth services for its members. Please welcome Mr. Walter Waway Bacareza. We are also fortunate to have with us today the COO of Ayala Healthcare Holdings. He is at the full, including Family Doc, their venture into primary care. Please, ladies and gentlemen, please welcome Mr. Rene Figueroa. Our next panelist is a Chief Science Research Specialist at the Department of Science and Technology. She is the focal person of the Philippine National Health Research System, led by the Philippine Council for Health Research and Development. Please welcome Ms. Merlita M. Opeña. To join our panel is
of Mindanao Health that was just presented by Dr. Martha Cayadan is indeed a very comprehensive experience that I hope would be replicated eventually in our effort to make sure that the imperatives for sustainable implementation of primary health care is indeed taken care of. And so, since our time is very limited, and I was surprised with this, we have 7 speakers in our panel, and we were given only something like, 40 minutes. That means you have to speak, or I'll give you about 4 to 5 minutes each to be able to comment and give your reaction to the presentation of Dr. Cayadan. So may I start with Dr. Walter Bacareza? Yes.
Good evening, everybody. It's such an honor to be here with you guys. For me, sir, and ladies and gentlemen, I think universal healthcare is within reach. I spoke with the President Duterte, and I told him we can win this war within your term. And we have to, well, Secretary Ubial is right, we have to work on the gains made by the previous administrations, by the previous secretaries. And it's within reach. The membership war is practically over because of the sin tax bill. Everybody in the Philippines is practically members of PhilHealth. In fact, according to Budget Secretary Jokno kanina, there's no need for IDs. if you're a Filipino, you're a PhilHealth member. Next challenge maybe is accreditation. And I've worked with Visayas Health when I was in Visayas, and I'll be working with Luzon Health very soon. Accreditation is the next war that we have to finish, and we can finish that within the next few months. The challenge, I'm surprised, sometimes the challenge is DOH is not giving license to the facilities that they have spent on. So what's the problem? I think, Sec, during your time, it was envisioned that since PhilHealth was very slow in accreditation, let PhilHealth license, DOH license it, and you will automatically accredit it. I even gave this challenge to Secretary Ubial.
Ayaw nasunod.
Nasusunod po. Pero minsan, sometimes it became more difficult. So, my challenge to Secretary Obial in one of our meetings was, if whatever you DOH license, I will automatically accredit, why don't DOH license automatically what I accredit? So, baliktaran, pabilisan. We have to move fast because that is the key. We don't have time. Next challenge would be all the Filipinos that we have deemed as members, when they go inside the accredited facilities, they have to be able to access national health insurance benefits. That is the next key. And the last battle would be no balance billing, which means pag mahirap ka, no bayad-bayad para sa'yo. Ganun lang kasimple. And I think we can do that. I have seen packets of best practices in Mindanao, in the Visayas, wherein it was government was able to influence private sector by letting government, by making sure that government is earning every time they serve. They can get so much money, and I've actually learned that mantra from Secretary Dairit, and I even call it the Dairit Doctrine. It just means that when the poor gets sick, they go to government, and it will be PhilHealth who will pay for the services. And if they will earn so much money, the government hospital, they will be able to improve themselves so much that even private sector will go and patronize government hospitals. And I can actually trace that by looking at the data on government employees and private sector employees patronizing government hospitals. And what I saw was that private hospitals having high quality at high prices in order to, well, combat this threat from government, they're actually maintaining quality and decreasing prices. And if poverty is defined as the absence of choice, once we give the poor the choice whether to go to government at low price but quality is increasing, or going to private sector which is high quality and price is going down, then maybe we can say we have won this war against poverty. Thank you very much.
Maybe isang comment ko lang dito is that a good number of our people and even our health professionals don't really understand ano bang ibig sabihin nitong universal health care. And the unfortunate thing here is because there is a misconception that universal health care means free for everybody. And kaya nga, to me, it still is very important that we have, unfortunately, I think na pumasa na sa House committee yung having a national ID system. There has to be organization as well as rationality in so-called operationalizing so-called universal healthcare. Hindi ito pwedeng basta't sino-sino lang pagpasok, akala niya libre na siya. And everybody claiming that he's poor. That's not universal healthcare. And maybe that really entails a more in-depth discussion. But dito sa ating panel ngayon, iba yon. So may I ask Rene Figueroa of Ayala Health to make some comments on this presentation of Dr.
Yeah, thank you. You know, we in Ayala Health, we'd like to think that you know, we're trying to play the role that the private sector can play in addressing the problem of healthcare in the Philippines. For most of the day, I think all we've heard about the challenges that the Filipinos face at different levels, throughout the country. And these are the same issues that we saw. And when we started to take a look at what can we do to address this? What can we do to help Filipinos get better quality care? And for us, the simple concept was, why don't we address the problems at the local level? So we took a look at different locations, focusing on barangay health stations, where the need was very prevalent, where the needs of the patients, and this is not only those who could not afford, but as the point was made earlier, it's for all the patients in that area. And so we said, all right, where are those stations, and how can we help? And so we identified key locations, and we came up with 2 pilot clinics. A very brief history. These 2 pilot clinics were in Buhay na Tubig in Cavite, and in Las Piñas, CAA Road. The objective was we actually wanted to coordinate and help the barangay health station deal with the number of patients that were flooding their places. The number one challenge there were no doctors. There were no doctors, and there were a huge number of patients that were trying to get services. So we relocated. The concept was, why don't we establish a clinic that will provide consults at a very, very affordable price, and that will prevent the patients from doing what the Filipinos normally do. The moment you feel something, you go to a specialist. That's what we wanted to change. We wanted to reinforce the behavior that you don't have to go to a specialist, you don't have to go to the ER, come to a primary care clinic first. So you get the consult. If you need diagnostic services were available. We had simple imaging with the X-ray, and we had ultrasound, and we had simple diagnostics as well. After that, if you needed medication, we had an in-house pharmacy. Okay, we sold generics and branded. They were all there, right? So it was a one-stop shop. The idea was we tried to take care of the patient from the moment they walk in the door, do all the services to the time they come out, they stepped out. So those 2 pilot clinics, after a year, we had 13,000 unique patients after 1 year for those 2 pilot clinics. And the wealth of data that we were able to gather was astounding. You could get incidences of disease, the demographics that accompany these, and it's just it's a data analytics mine. It's the treasure that's contained in this information is outstanding. And so we said, all right, let's build on that success. So we added 4 more clinics. So towards the middle of last year, we added 4 more clinics, and to this date, we have a total of 6. We have over 22,000 unique patients in our EMR. It's in the family doc is totally paperless. Even our imaging is digital. In fact, if a patient needs their reading right away, a patient gets their X-ray, we send that through the net, they get the reading, and in 20 minutes, we can actually give them the results. So it's that quick. And all of this at a very affordable price. Very, very affordable. But that's the key. Many successes. No? There were challenges that were mentioned today that I think are worth mentioning that we faced as well. Challenge number 1, where do you get the doctors? Right? It was mentioned by Gabe earlier. Filipinos, as soon as they graduate, and this is not any different even with the doctors that we have, right? They want to specialize. So how do you make them stick? How do you give them a career in family medicine? So, apart from the model in Family Doc gives them full employment with all the benefits, and they're, for a fresh medicine grad to get a full-time job and all the bennies and the appropriate compensation, that's a good start.
Rene,
Yeah.
with your experience, since these were all in urban areas, pwede bang mag-usap kayo ni Dr. Kayadan, and maybe, the direction has been to Mindanao ngayon for the last year or so. Pwede bang itry mo yon? And the reason for that is because I suppose the situation in the areas where the Mindanao Health is doing its work is quite different from that of Muntinlupa ba yung sabi mo?
There's Cavite and and Muntinlupa. Why not? No, but as the way we're building this is we build it in a hub and spoke. So we really have to plan the expansion along certain corridors, so that again the objective is to provide the quality care at an affordable price. And so the way we cluster all the clinics will lead to synergies that will enable us to deliver that affordable care. So that's the challenge. So anyway, we're talking about challenges. So number one is the doctors, no? And remember, we all have pharmacies also in all of our stations. Pharmacists are in hard supply and tough supply as well. And so we have a vision of building 100 clinics within the next 3 years.
The reason really that you are presenting today is really a part of a whole so-called health system reform that we should undertake. And unless we really do that, we'll be getting packets of problema sa radiologists, problema sa for your pharmacies. And to me, this is really part of what we should do in terms of a so-called national health reform agenda.
That's a very good point that you raised. No, that's a very good point that you raised. In fact, so we have to address all those challenges. But I think one of the key successes that we have to give credit to is the level of coordination that we have with the barangay health workers. Without that cooperation, there's no way that the population within that area can benefit. So some people might think we're actually taking away from the barangay. No, we're not. We're actually helping them. So a lot of our activities at the barangay level have to do with actually visiting them and doing a lot of projects together with the barangay health stations. And we get to meet the patients firsthand, so they actually come to the clinic, and that's it's been a very good experience so far.
Let me jump na siguro dito since you are talking of certain shortages like you mentioned about, let's say, pharmacists. No? May we get some comments from Dr. Yolanda Robles from our UP College of Pharmacy?
Actually, that will be part of my discussion. But
3 minutes or 5 minutes na lang eh.
yeah.
Kasi, that's why.
Directly answering,
Yes.
we have addressed with the passage of the new pharmacy law, we have addressed the need for more pharmacists by reclassification drug outlets, which means that for those carrying over-the-counter medicines or less medicines than the usual, then this will require supervision. But for full-blown pharmacies, then they have to have a pharmacist who will manage it. And in addition to that, we have expanded the roles of the pharmacists in the new law, which means that it is not only about the provision and making sure that medicines are available in a particular facility, but also we will be engaged in primary health services, which we have started right now. So we now have a new mandate to be part of the universal health care, to be active, and also to do capacity building, as what was mentioned by our speaker, with regards to preparing our pharmacies to help the community also in handling simple health promotion activities, the health screening activities, and in fact, immunization is one of them. And this, we will not pursue this without making sure that we are prepared for such role.
Dr. Robles, ano ho ba ang ating production of pharmacists annually right now?
For now, just the recent board examination, we have more than 3,000 pharmacists, new pharmacists, which is actually an increase from the usual, but we usually have 2 board exams in a year.
Just to give you an example, there is a country in Africa na about 5 years ago, I was told they only have 3 pharmacists. The whole country. Ganun kalaki ang shortage. And yet, here in the Philippines, you are producing more than 3,000. So, if you really look at it in terms of need, with 3,000 production number of 3,000, should more or less be able to fill up the needs of the country. So maybe can I ask Merlita, Ms. Merlita Opeña of DOST kung merong tayong any research or any activities that are directed to solving some of the issues that were raised by Dr. Kayadan?
I'd like to, working on the building block on information, research, and innovation. Also, noting the results of the Mindanao Health Project, which was presented. In the Philippines, we have the Philippine National Health Research System, which was passed into law in 2013 with the DOH, DOST, CHED, and National Institutes of Health as the pillars, but also working with the private sector. So this is a way of converging our research agenda, where we are going to invest in terms of health research, and that would also, the topics would include healthcare financing, health service delivery, technology development, socio-environmental programs. And in terms of capacity building, we're also investing in institutions and human resource outside of Metro Manila, and that's the marching order, to really build the capacity of the regions. But I think the challenge is, based on the results of the project, is how do we communicate the results of research so that it becomes a benefit to the target audience. So in this case, we really need to engage other disciplines aside from the researchers, people from communication, people from marketing, people doing advocacy, because like translating research results into policy, it's not a linear process. It's, there has to be a lot of creative process, and we'd like to learn from the lessons of the Mindanao Health. If you can document how the results of your project were adopted by the local government, because translating research to policy is not only policies at the national level, but also at the local levels. So if we can share the experiences of the project. In the end, the process of communicating research as well as adopting research results, this will entail change management. And for example, the project now on the Philippine Health Information Exchange, which you started, sir, when you were in the DOH, if that will be put in place, all the health centers from the barangay up to the hospitals will have to be using the electronic medical records. And if you just think about it, it has to be managed, that change has to be managed, and there is the issue of governance and organization. Thanks.
Sure, Doctor.
Our project is not a research. Our project is we closely work with the regional offices as well as the local government units to support them in their own goals. That is the reduction of maternal and neonatal health, as well as improving family health care in terms of reducing the FP unmet need. So we are partners in the provision of services. So we are not, it's not a research.
We've really broadened the definition of research. That's why we say research and innovation. So there are innovations that were presented in your projects that will have to feed into the health systems for improvement.
Siguro it's time to also consider that since this is really sponsored by PHAP, and we have here Ms. Cecilia Sison, who can make some comments with regards to Meta's activities with regards to medicines.
Thank you, sir. Just a clarification, I'm not a member of PHAP, although PHAP is a member of Meta. I'd like to use up my 2 minutes to talk about 3 points, and I'd like to anchor it on the project that was discussed by our resource person, but also looking at the other programs that have already been discussed earlier. First, the strategy of generating demand, which is a good innovation, because our work is not only directed towards supplying, but also making sure that our services and our work is used. For example, information generated and the the information generated and the services that are provided are also being used and demanded. So in generating demand, the point that I wanted to raise was I think we can do that better if we engage other people, we engage other stakeholders, which is our bias. It has worked in many other programs, and it will work in future programs, I think. And we're not only talking about people who are in health, we're not only talking about government agencies or institutions that directly provide health, but also consumers and patients. So we've seen that work. In terms of increasing supply, the other strategy, we've noted that there's a lot of already resources that are being poured into health. We've seen that in the increase in budget. We've seen, for example, that in the DOH alone, there is a 15 or 16 billion allocation just for medicines. I think we need to be able to maximize that and make sure that there are no overlaps in the DOH. For example, we'd recommend that programs are seen as an integrated thing rather than each one doing their own program, so that we don't overtax our resources, which are scarce, and also we prevent overlaps. And finally, on the point of sustainability through better policy and planning, we've seen frameworks are in place, policies are in place. There are reforms that are also being planned. We'd like to suggest that we focus on implementation, that we focus on aligning, and avoiding overlaps. And finally, establishing our accountabilities and being conscious of our responsibilities as stakeholders. Thank you.
Thank you. It was also mentioned by Dr. Kayadan that among the most neglected through all these decades. And public information is so important. And how do these available services be made known to everybody, and that they have this inherent right to have good health? So the media is really very important on this, and I'd like some comments from Attorney Michael Toledo of MVP Group of Companies.
Maraming salamat po. Magandang gabi po sa inyong lahat, Secretary Ona. First of all, I'd like to thank Ted Padilla of PHAP and the organizers of PHAP for again inviting me. I was also a panelist last year. So it's possible that I said something right, or I said something that they like, because I'm back. But just very briefly, Mr. Secretary, if I may, I would like to briefly touch on 3 points, essentially. One, the overarching vision of the MVP Group as far as healthcare is concerned. And perhaps number 2, touch briefly on technology and how we leverage technology, being a technology company. And of course, our PPP projects with government. The MVP Group, as you know, perhaps we're the largest owners of hospitals in the country. We have about, as of the moment, as we speak, perhaps 12 to 13. The latest acquisition was Delgado Clinic. And it was a bit sentimental for me because I was born in Delgado Clinic. And we intend to, like what we did with the other hospitals, we intend to expand, upgrade, and bring it to world-class standards. And of course, and to be very candid about it, to be, of course, a profitable hospital. Because a hospital that is profitable, any business that does good, can also do a lot of good, doing a lot of CSR and charitable work. That is the mindset of the whole group. As of the moment, we have a little more than 2,000 hospital beds. We intend to go to 3,000 or even higher as we go on. In fact, we have realized that it is not easy now to buy in hospitals. They're not, we see that they're not much out there for sale, although we're still looking at hospitals in Cebu. So we are now open to the idea of greenfield projects, not just brownfield. And MVP's vision is that perhaps we can have a Cancer Institute, specialty hospitals for children, for cancer, for certain diseases, or the number one identified or top 3 identified diseases in the country. On technology, as I've mentioned, we are a technology company as well, and innovation. We pride ourselves as being very innovative as well. And we have used e-health centers. Lately, last February, if I'm not mistaken, we launched 2 e-health centers in Leyte. Those that were affected by Typhoon Yolanda. And the idea being is to provide healthcare, immediate healthcare, by the use of technology. Those from far-flung areas have access to the kind of medical treatment and advice that can be given. And phase 2 of that, I was made to understand, was the activation of lab functions. Also, lately, if you've read the papers, we entered into an agreement. It's a form of PPP as well, wherein employees from the land bank can buy, using their cell phones, affordable medicines without bringing out any cash. And that is one of the new PPP projects that we have, and which we're very grateful to the officials of the land bank for making this a success. It's also a project with Unilab. Number 2, we also did a lot of PPP projects, in fact, with the help of no less than Secretary Ona, because it was our vision that we should help government public hospitals. So we focused first on Rizal Medical Center. And we're proud to say that by providing them organizational upliftment, capacity building, no dole-outs. There was no dole-outs at all. It was really strengthening their capacity, organizational capability. They have an ISO certification already. And with your help, sir, we were able to enter in an agreement with several AFP hospitals. So we are now, this is our 3rd or 4th year of an arrangement with the different hospitals of the Armed Forces of the Philippines, wherein we are upgrading, uplifting the quality of the hospitals that they have. Because really, seriously, if one takes a look years back about the quality of the hospitals of our armed forces, it's sad, it's quite pathetic. And these are the men and women who risk their lives to protect us from all types of violence, whether internal or external. So now we're making sure that our soldiers will be properly taken care of. And same holds true with the PNP. We met with General De La Rosa just recently, and we are hoping to enter into a memorandum of agreement as well, because we looked at their hospitals in the PNP, and there's much that needs to be done, indeed. So this is, again, a clear example of PPP. And just last point, because I know time is running out. We, for example, I just want to cite a particular example of how we use technology well. In the Asian hospital, for example, in Alabang, we use RFID to ensure, to monitor where the patient goes. So to ensure the flow of patients in the hospital, for example. As mentioned also earlier by the Ayala Group, we also make sure that we have everything, all the records, digital. And it's up in the cloud, so it can easily be recovered as well when necessary, or even sent abroad if necessary, to be able to get the kind of opinion that is necessary for a particular kind of ailment. So these are what the MVP Group is doing. And perhaps to end, you did mention the use of media. Of course, any way we can coordinate with PHAP and with the different government agencies and with the private sector, the use of our media assets. We're proud to say that TV5 is number 3. Undisputably, we are number 3. So anytime that you need that kind of publicity, as well as from the Philippine Star and the other papers within the group, including Interaction, let us do know, because we are ready to help. Maraming salamat po.
Thank you, Mike. It was not too long ago that people thought, or or a good number of experts thought that primary health care is not in the realm of the private sector. And I think our panelists here have shown that indeed PPP can work very well with the implementation of primary health care. And maybe for our last commentator, may I ask Dr. Queenie Ragas of the Office of the President, since you will be the one that will be pushing for this and hoping that the President really would support this with regards especially to health.
Thank you very much, Dr. Ona. Good evening, everyone. I'd like to start my talk with a rejoinder of our presenter. Bringing the hat of being an implementer, being a doctor to the barrio myself. I was deployed in Clover, Surigao del Norte, and I did such health system strengthening also, but I'm tapping corporate social responsibility of mining companies to strengthen local health systems. Strengthening health systems, whether local, subnational, or national, global, is everybody's business. And it's a challenge due to a wide gap between theory and practice. While we recognize that governance is an important factor in health systems performance, the concept is poorly absorbed or understood. Sometimes it will be often subjected to ambiguity, vague, and sometimes competing notions and ideas. So we're now challenged how to see it, the governance as a role, and how to address its weakness. Sometimes bottlenecks lies in the gaps of governance agenda and our existing capacities. Sometimes there are informal and formal governance, and in attention to the socio-political power dynamics. So, in my 4 years experience as a health systems development manager and practitioner in the field, it's really tedious. Being a faculty also of the Development Academy of the Philippines, we are capacitating public health and health systems managers and practitioners. For the past 4 years, we've been educating doctors of the barrios. I think we have already 8 batches, and we have master's degree of it. And then my reflection is that we have initiated rigorous attempt to urge critical mass of reformers to judge their own health systems, even municipal health officers and local chief executives by the Zwillig Family Foundation. But these area, the practitioner should define problems in forms of performance deficiencies and access or assess the proposed solutions. In this approach, analytical methods will be used and causal diagnosis and policy development. Actors in health systems became aware of the multiplicity of the social factors and the social determinants of health and distribution of roles and responsibilities. I have this experience when tapping corporate social responsibility of mining companies. The challenge is their ability to take on the role. So governance is really, and leadership is really critical in strengthening health systems and development. Now, as for the Office of the Cabinet Secretary of the Office of the President, it is mandated under the Executive Order 99 series of 2012 to integrate and coordinate with other national government agencies for the program of this administration to be effective. And then we also wanted to have a grassroots participation. So part of our effort also in the health systems governance is a collaborative framework of participatory governance. So last year, we initiated a social development agenda initiative summit in Davao, and we invited civil society organizations, government agencies, and then we have also private sector. And then during that workshop, national workshop, the output of those rigorous interaction and collaboration were being incorporated in the Philippine Development Plan. So it's actually a health systems governance framework that we try to experiment in the whole governance scheme. And now there's also a system in place wherein cabinet cluster system and cabinet assistance system is working at, wherein sectoral efforts are being monitored. So part of that, the Performance and Projects Management Office is also monitoring human development and poverty reduction roadmap. So that's the cluster I'm shepherding. And then maybe this discussion, this dialogue will be a good input for agenda in the next HDPR cluster meeting.
Queenie, meron lang ko itatanong sa iyo bago matapos. No? Since you are in the office of the President and the Cabinet Secretary, nakakaintindihan ba na both in primary health care as well as in our hospital care system in the Department of Health, na pwedeng ang private sector sumali? Yung PPP. Kasi, as you know very well, so many people don't understand it. And when they think, or when we talk of PPP in health, para bang all of a sudden the left right away rises and gives a very strong so-called negative approach to that. Ano bang natatansya mo doon?
Actually, sir, there is a proposal that PPP will be tapped. And in fact, there are 3 major projects of the DOH.
The first thing na pinuntahan ka agad was Cuba eh. So
Actually,
it was kind of surprising to me, but at the same time, a little bit worrisome. Baka ang sabi, sundin natin yung sa Cuba.
In the Office of the Cabinet Secretary, sir, pushing for the PPP. In fact, the budget for health, the DOH, has 3 big-ticket projects on PPP. And then myself, I'm also advocating for that. Not only for mining companies in the area of where they're operating, but also the pharmaceutical industry. So that's what's my reflection. Maybe this forum can be an input to that, sir. Thank you.
Well, our time is up, way, way beyond. And I'm sorry to end this very interesting discussion. And I therefore would like to thank all our panelists for a fairly lively discussion on this issue. Thank you.
Thank you, Dr. Enrique Ona. Thank you, Dr. Martha Cayadan, Mr. Walter Bacareza, Mr. Rene Figueroa, Ms. Marlita Opeña, Dr. Queenie Ragas, Dr. Yolanda Robles, Mrs. Seal Season, and Attorney Mike Toledo for your fruitful discussion. Please affix your commitments on our UHC wall. Our next speaker was Secretary of the Department of Health in 2010. Prior to this, she was the Secretary of Social Welfare and Development between 2006 and 2010.